A quality minute with Cole Beeler. We got an emergency. Your patient is freaking pooping like tons. And you're like, maybe it's C. diff. But you know you shouldn't over-order tests. And at the same time, C. diff can kill people. And the angel on your shoulder says, stay cool, baby. But the devil on your other shoulder says, better not risk it. Let's check just to be safe. And we recommend a lot of things just to be safe, right? So what's the big deal? Well, the problem is that our current test for C. diff, the PCR, is no good. In a study out of Stanford, 716 patients were screened with a PCR. Half had diarrhea, half didn't. And they found an equal amount of PCR positivity between the two groups. Additionally, there was no difference between carriers and non-carriers as it relates to progression to colitis. So not only can you not trust a positive test with a 23% positive predictive value, but the PCR doesn't even prognosticate who will get legit disease. There are a lot of things that we can do just to be safe, like putting ourselves in whole body casts before driving. But that doesn't mean that they're worth doing, because the consequences of false positives are exposure to unnecessary antibiotics, longer hospital stays, development of confirmation bias, financial penalties to the hospital, and public reporting of how we give our patients C. diff. At our institution, 84% of C. diff PCRs are negative, and of the tests that are positive, 50% had other causes of diarrhea discovered on retrospective review. So there is a lot of reflexive C. diff tests being ordered. To get a positive PCR, you need the gene for the toxin, and this gene must be transcribed and translated to actually make the toxin that actually causes the C. diff. But just because you have the genes doesn't mean you're actually wearing them, and genotype does not equal phenotype, and therefore a positive PCR may just mean colonization. So what if we look for the toxin? I can get an idea about what animals live in the woods around my house by knowing what type of poop they produce. Similarly, I get an idea about whether C. diff is actually causing problems by the toxin it produces. This is the most specific test for C. diff, but unfortunately not as sensitive as we would like. A test with better sensitivity is the C. diff GDH. All C. diff have this, but it has nothing to do with the toxin gene or toxin production. As an example, clowns all have red noses. This is the GDH. But some clowns are nice, and some clowns want to eat your children. In the same way, not all GDH positive C. diff causes disease or is even capable of making toxin. Since no one test is dominant, the IDSA is now recommending two-step testing for C. diff. This is the algorithm that will be happening behind the scenes, but I'll break it down for you. We start with a combined GDH toxin test. If both are positive, then you've got C. diff. This is legit disease. That clown will kill you, and you should treat with vancomycin, isolate the patient for 21 days. I'll only remove isolation if the patient's symptom-free. On the other side, if both are negative, that's not C. diff, and there's really nothing to see here. If the GDH is negative and the toxin is positive, that really doesn't make too much sense and should happen very rarely. This is like a guy who looks like a clown but isn't. If you get an invalid, you could consider retesting if the C. diff suspicion remains high after dealing with other causes of diarrhea. If the GDH is positive and the toxin is negative, the lab will reflex to a PCR. If the PCR is negative, you don't have C. diff. If the PCR is positive, it takes some thinking. This may either be due to low-level toxin production or simply colonization. As such, decide on treatment based on the clinical setting. Is the patient still having diarrhea after I stopped laxatives? Are there signs of colitis? Is there no alternative explanation to the diarrhea? Regardless of your decision, we recommend isolating this group like they have legit disease due to the possibility of a false negative toxin, but this does not mean that they need to be treated. You may say, I hate making clinical decisions, and I would say, that's weird, doctor, but the consequences for undertreating this group is probably small. When comparing GDH positive, toxin positive patients to the positive negative positive group that I just talked about, there was less likelihood to progress and to recur in the latter that would support a wait-and-see strategy for deciding on treatment. Like, does the diarrhea stop when I hold the lactulose? In other centers that have changed from PCR-only testing to two-stage testing, there's been a 50% reduction in positive tests without an increased rate of C. diff-related complications. This strategy will provide faster turnaround time, less patients in isolation, less false positives, and is now the standard of care as recommended by the IDSA. But just because we have a more accurate test, it doesn't mean we should continue to practice reflexive diagnostics. C. diff testing should only be sent if there are 3 or more liquid stools in a 24-hour period, the patient has signs and symptoms of colitis, some sort of predisposing condition, and other causes of diarrhea have been excluded. The bare minimum that you need to know is that how we are C. diff testing people is changing. If you get a likely colonized, it is probably not C. diff, but use your clinical judgment on who needs treatment. If it says invalid, resend stool only if the clinical picture of C. diff persists. And again, don't test for C. diff just to be safe if there's an alternative cause that's more likely. Thanks for watching. Email me with questions and follow me on Twitter.